So now I would like to kind of begin the side effect part of this discussion today. So we have first Bianca Santomasso, who's a neurologist and who has been helping us manage all the neurologic toxicities of immune checkpoint blockade. And I think just the way we'll structure this afternoon to stay on time for our break, and because I know Bianca has a flight, we're going to just do the questions right after each of the next three speakers, so we end break at 3:20 on time. And Bianca, thank you for sharing neurologic toxicities of immune therapies.
Great. Thanks for the invitation to this great conference. I'm going to be talking about neurologic toxicities, which fortunately are among the rarer of the immune-related adverse events. These are my disclosures, which are not related at all to this talk. Neurologic immune-related adverse events are similar to other adverse events related to immunotherapy, unpredictable. Unfortunately, some may be permanent, and they're occasionally fatal. Initially, because they are rare, they were really captured in case reports, such as the ones illustrated here, but there were many more. But now the field has been coalescing, and I think there's greater appreciation of these events, so there have been a number of published case series. And with these case series, it still seems that these are relatively rare events, with the severe events hovering between around 1 to 2 or 3%. But they are among the more serious events, and this was a recent systemic review and meta-analysis of fatal toxic events secondary to immune checkpoint inhibitors. And while neurologic events, you can see here actually, are they're lower among the number of adverse events reported compared to, say, for example, colitis and pneumonitis. They do have a signal as far as the fatality rate, and that's when you even take out myositis, which some consider part of the immune system, or at least it's kind of cutting the intersection between neuro and rheumatologic. And so really, since this is a talk about management, the first step to management is recognition. So, understanding what these events actually look like. So we actually decided to conduct a review of neurologic adverse events here at MSK. We identified all adult patients treated in a 7-year period and looked at the spectrum of presentations and the demographics, tumor types, time to onset, and treatment. And among about 5,000 patients treated, we identified 81 patients who developed grade 2 or greater neurologic toxicities. This is probably an underrepresentation, but these were patients who we all got a very good sense of being able to get the true descriptors of the spectrum of presentation. And what we found is that actually the neurologic adverse events are quite diverse. They affect both the peripheral nervous system, which means the peripheral nerves, neuromuscular junction, and muscle, and the central nervous system. So we're talking there about spinal cord and brain, and really span everything from a sensory neuropathy to a Guillain-Barré-like syndrome, myasthenia gravis, to a full-fledged encephalitis, posterior reversible encephalopathy syndrome, which is probably more along the lines of a vasculitis. Even paraneoplastic neurologic syndromes, which were not previously very well captured in the case reports in the literature. And we had several cases here. And along with those diverse types of descriptions, the presentations, the clinical presentations, what you see in a patient can really vary. Anything from headache to numbness, tingling, foot drop, to severe altered mental status, personality changes, new Parkinsonism, seizures. Of course, you get the more general reports of gait change, which could mean any number of things. And also through this retrospective review, we learned a lot about when these events tend to occur, and we found, interestingly, that the most severe neurologic immune-related adverse events occur within the first 8 weeks of starting treatment. So they can occur late. There is a range here, but really the majority of them are clustered kind of within the first few weeks, the first 2 or 3 doses of the immune checkpoint inhibitor. And again, you can see the large phenotype here. And because we know, of course, that cancer can really metastasize to many different parts of the nervous system, neurologic toxicity really still is a diagnosis of exclusion, but I'm going to go through some of the things that make us suspect it more. As part of the workup for neurologic toxicity, it's imperative to rule out CNS metastases, stroke, and infection, which can occur in cancer patients. But really, you can be helped a lot by both understanding when the events tend to occur, so early, although you have to have vigilance for looking late as well, but also being aware of a compatible history and the temporal onset of neurologic signs and symptoms or new worsening symptoms. This is kind of your toolbox, which can be very helpful: MRI of the brain and spine, a lumbar puncture for CSF analysis, and I'll get a little more into that, histopathology of the affected site, so whether that be a nerve or a muscle, if you think that that's what's affected, EMG and nerve conduction studies, EEGs, and certain serum panels. And another key point, and I know this has been pointed out by several others, is that toxicity of organ systems can be other organ systems concomitantly or previously can be an important clue. In other words, these toxicities appear to lump together. And so a patient, for example, who had a history of recent hepatitis that they're recovering from, presenting with new neurologic symptoms, you would be especially concerned, and this would jump much higher on your differential. So I'd like to go through a few cases. I think that that's a helpful way to think about these and just the diversity of presentation and management. So the first patient is someone who has a headache. So this is a 55-year-old woman with metastatic melanoma. She starts ipilimumab and nivolumab. And at home, after 3 doses, she develops a fever, and not only a fever, but she feels like a holocephalic headache and neck stiffness, and she also has an episode of vomiting and photophobia. However, her mental status is pristine. She's able to provide a very clear history, and she also tells us that she has joint pain at this time. So now we're thinking about our differential diagnosis. I think we are thinking about maybe a process involving a meningitis. Maybe it's an aseptic meningitis, but we also have to consider, could it be an infectious meningitis, bacterial over viral? Could she have immune-mediated hypophysitis? That can also present as a headache. Or could she have leptomeningeal metastases from her melanoma? So she's admitted to Sloan Kettering and has a normal MRI, including a normal pituitary MRI. Sorry, this got a little bit messed up in the transfer. A lumbar puncture is done, and it shows negative cytology, negative cultures, so we know we're not dealing with leptomeningeal metastasis or an infection. However, it does show a lymphocytic pleocytosis and an elevated protein. And she's treated with dexamethasone, 4 milligrams twice a day, which is then tapered over the course of the month with a complete resolution of her symptoms. So this is aseptic meningitis. And what we've learned about this is that, other than the characteristics which you see here, which I won't repeat, is that they tend to be very treatable cases. You can often hold the immune checkpoint inhibitor and get away with even starting a pretty low dose of corticosteroids, oral prednisone, 0.5 to 1 mg per kilogram. But CSF is really helpful because, again, we're trying to rule out leptomeningeal metastasis and other infections. And we have had a couple of cases where we've actually re-challenged patients with checkpoint inhibitors after they've developed this and the aseptic meningitis hasn't recurred. Patient 2 is a little bit different. So now the chief complaint is disorientation and memory loss. So this is a 67-year-old man with bladder cancer who starts treatment with nivolumab. After 4 doses, he develops confusion, decreased PO intake, generalized weakness, and a possible mild fever at home. So now our differential diagnosis, again, we're thinking in the back of our heads, is this an infection, CNS or systemic, a metabolic derangement? Could he have had a stroke or a seizure? Does he have new leptomeningeal disease or CNS metastatic disease? On exam, he has, the most prominent thing is that he really has 0 out of 3 recall. So he has very severe memory difficulties. He can't remember the name of his cancer doctor, his diagnosis, or the name of the hospital. There are no other focal findings. So he's admitted, and on his lumbar puncture, there's a little bit of a white cell count increase. Otherwise, all viral PCRs, cultures, West Nile virus, New York State encephalitis panel, and cytology are negative. He is hooked up to EEG, and it shows not seizures, but it shows this focal sharp waves, which are suspicious for seizures. And initially, he started on IV steroids, 1 mg per kg per day of methylprednisolone. But his exam starts to worsen. And this is really, I think, a key point for anyone caring for these patients, is that it's very important to monitor the exam evolution with your interventions. I think we're still really trying to understand what the optimal interventions are and the optimal management, and it's not 100% clear in all cases. So the most important thing you can do is continually reassess what you're doing. So in his case, we saw he was getting worse. He also had an MRI which showed this medial temporal flare hyperintensity, which can be seen in other cases of autoimmune encephalitis, idiopathic. So we knew, based from the literature for these syndromes, that we needed to up the treatment. So he was actually started on pulse dose steroids, so 1 gram of solumedrol a day for 5 days, in addition to IVIG. And with that treatment, he completely returned to baseline. So encephalitis, in contrast to aseptic meningitis, is different. It's not exquisitely steroid sensitive, and you often have to do pulse dose steroids or at least some dose of steroids with IVIG or plasmapheresis. And really, this is taken from the literature from autoimmune encephalitides not related to checkpoint inhibitors. And you have to always be on the lookout for cases of no improvement. Your neurologist can help you a lot with this, because one of the things that's sent out, in addition to ruling out viral encephalitis, which is imperative, is also knowing which serum test to send. So there are certain paraneoplastic or autoimmune encephalopathy panels, and there have been reported cases, including at this institution, of patients who've had antibodies positive for these, and so your neurologist can kind of help you decide which ones to order. Again, MRI may or may not show those flare hyperintensities. More often, it's completely normal. And it's also important to, most patients are started on prophylactic viral coverage while waiting for the PCRs to return, since an infectious encephalitis can appear identical. This is another man who I recently saw who has metastatic bladder cancer. He also developed suspected encephalitis after being treated with pembrolizumab. Interestingly, he developed hepatitis first, so again, the toxicities coming together. 1 month after the hepatitis, and actually his checkpoint inhibitors were being held at this time, he developed progressive confusion, incoherent speech, and right ptosis. And he had this bilateral insular flare changes. So we tapped him, and he had a negative infectious panel, only slightly elevated cerebrospinal fluid protein, normal ESR and CRP, normal other room labs. However, we sent a serum paraneoplastic panel, and it came back with 2 positive antibodies, a striational antibody and a voltage-gated calcium channel antibody. Initially, he was started on dexamethasone, and the point here is that the serum paraneoplastic panels, when you send them, they don't come back for about 10 days. So initially, he was started on a low dose of steroids, but he became worse. Then the panel came back, and at the same time, we realized he was getting worse, and he was treated with pulse dose steroids, plasmapheresis, IVIG, and a prednisone taper, and now he's slowly improving. Interestingly, post-plasmapheresis, the previously positive antibodies, these 2, returned negative. However, it's really unclear at this point what's mediating the encephalitis. Is this just a marker of a T-cell response, or are these antibodies actually pathogenic? The third patient comes in with a chief complaint of trouble walking. So this is a 68-year-old man with colorectal cancer. He starts treatment with nivolumab. And 4 months later, while on treatment, he develops gait difficulties, which he just describes as a sense of unsteadiness. There's no ataxia noted on examination. So he is admitted and has a lumbar puncture done, which shows an elevated white cell count, an elevated protein. And again, the cytology is negative, but it does show lymphocytes. And he has an MRI of the spine, which shows, I think you can maybe see here, this leptomeningeal enhancement, which actually initially was thought, oh, could this be leptomeningeal metastasis? But again, the cytology was negative. So he was started on dexamethasone, which was tapered over the course of a month with complete resolution of his symptoms and, of course, the neuroimaging findings as well. So immune checkpoint inhibitor-associated neuropathy is kind of a broader group. There are many different types. I'm not going to go into too many details other than to say that they can range from a simple mononeuropathy to affecting multiple nerves, sensory and motor involvement. And the treatment is generally involves some combination of neuropathic pain medication. These are often painful neuropathies, corticosteroids, IVIG, or plasmapheresis. And in this particular series, which was selected by patients for whom an EMG was ordered, 50% of them were hospitalized at some point, although many of the hospitalizations were short. There is a poor correlation between the clinical severity and electrophysiological abnormalities, but all of them were abnormal. And I think a question I get asked frequently is, what's the association between prior chemotherapy-induced peripheral neuropathy and this immune checkpoint inhibitor neuropathy? And we don't really know whether it is a risk factor. There is a suggestion that it could be, similar to diabetes or other nutritional neuropathies. So now we have a more severe case of someone who has trouble walking, but they also have facial weakness and double vision. So this is a 78-year-old man with metastatic melanoma, who I also saw in clinic. He had a solitary brain asymptomatic met at diagnosis. He started at Benivo. And then on cycle 1, day 16, he developed burning pain in his shins and a backache, as well as a right facial droop. So here we're getting a little more involved. Initially, the steroids were deferred due to mild symptoms. But then with the progressive back pain, he also started to develop weakness in his legs, and he was started on prednisone, 90 milligrams. At that time, he also reported double vision. So again, we're reassessing here and seeing that he's getting worse despite our intervention. So he was seen in my clinic, and at the time that I saw him, he reported his back pain was completely resolved with steroids, but he was too weak to walk. He had a complete lower motor neuron cranial nerve 7th palsy, a left cranial nerve 6th palsy, and bilateral leg weakness, decreased sensation to his knees, and absent reflexes. So I was very concerned about Guillain-Barré syndrome, which has been seen with checkpoint inhibitors. He was admitted. He had a negative MRI brain and spine to obviously rule out a compressive lesion, and his cerebrospinal fluid showed lymphocytic pleocytosis, not huge, but there, positive oligoclonal bands, and negative cytology. So he was started on a gram of solumedrol and IVIG and put on a 6-week prednisone taper. He left the hospital a week after starting this, much better, walking, his facial completely resolved. He was able to successfully taper off the steroids, but 3 days after tapering off the prednisone completely, his diplopia recurred, so we had to repeat the IVIG and give him a short course of steroids. I was very nervous about what this would do to his melanoma. He had, remember I said at diagnosis, a right frontal brain met that you can see right here. Actually, even after all these steroids, you can see that he's still had a very nice response to the intracranial melanoma as well as to his systemic melanoma. So for Guillain-Barré syndrome, typically the mainstay is IVIG or plasmapheresis, but we also are using corticosteroids in this context, really because this is not similar. It's a little bit different than idiopathic Guillain-Barré. There can be a lymphocytic pleocytosis, and we often see patients recovering more quickly if we add in the steroids as well. But it is critical to check the cytology, since, obviously a lower motor neuron cranial nerve palsy can also present from that as well. Patients can also have trouble walking, shortness of breath, facial weakness, and double vision from something that's not Guillain-Barré syndrome. They could have it from something like myasthenia gravis. In this case, the weakness is often fluctuating, but there can similarly be ocular or bulbar muscle involvement. It's often the case that these acetylcholine receptor antibodies are positive in these cases, similar to the idiopathic cases. And the main point I'd like to make here is that Orbital myositis, or kind of a muscle problem, can present very similarly. So it's hard to know without doing the electrodiagnostic tests and without sending these antibodies whether you're dealing with a myositis or whether you're dealing with a myasthenia gravis. And to make things matters even more complicated, what we've learned is that there can be an overlap between these three entities: myasthenia gravis, myositis, and myocarditis. So now when you encounter one diagnosis, it's often recommended that you send the workup for all three. The final case that I'd like to discuss is a 73-year-old woman with Merkel cell carcinoma. She had this PET FDG avid lesion here in her axilla, started treatment with anti-PD-L1, and after her first dose, the palpable axillary mass disappeared. She was very happy about that. But at cycle 3, day 5, she developed rapid onset of progressive incoordination imbalance, vision problems, and cognitive issues with profound short-term memory loss. We had seen this before. This looked to us a lot like a paraneoplastic neurologic disorder, so we sent a serum and CSF paraneoplastic panel, and lo and behold, it came back for this antibody called CRIMP5. So we started immunomodulation with steroids IVIG. She didn't have much improvement, so we increased it to cyclophosphamide and rituximab, and she did stabilize and improve. Although she didn't improve 100%, she did improve significantly. And notably, she had a complete resolution of her disease and has an ongoing CR. But what's interesting about this case is that we actually were able to look back at one of her early blood samples and saw that even prior to the onset of toxicity, she had a low titer CRIMP5 antibody here in her blood. This is her CSF high titer, plasma high titer, but this low titer was present in her blood even before she developed symptoms. So that's led us to studying, trying to figure out, are there pre-existing antibodies that we can use to kind of predict who would develop these toxicities? So to sum up, general principles of neurologic immune-related adverse event management is to not be afraid to call your local neurologist. If the functional status is impaired, if you have persistent or worsening symptoms, or just if you're unsure, hospitalize the patient if they have moderate to severe symptoms, or if you see a rapid trajectory of worsening. All of these diagnostic tests can be very helpful, especially brain imaging, some of the antibody panels I mentioned, and lumbar puncture to rule out other etiologies. EMG and EEG can be ordered by or guided by the neurologist as well to help figure out what's going on. The management involves holding the immune checkpoint inhibitor, in almost all cases, corticosteroids, but in severe cases, IVIG or Plex plus steroids. And obviously consider especially the pulse steroids and IVIG in cases such as Guillain-Barré syndrome or encephalitis. There have been cases where that have been refractory where rituximab has been used, and in case reports, even other things which block, for example, alpha-4 integrin blocker natalizumab, which is used in multiple sclerosis, has been used for refractory cases of encephalitis. So these are very diverse. I didn't even talk about all of the possible diversities, but I think you get a sense here at least that you should be on the lookout for multiple different types of symptoms. They're infrequent, fortunately, but potentially fatal and should be considered in all patients with neurologic symptoms. A knowledge of the symptom onset and the typical clinical presentations is a key to good outcome. We have seen that the earlier you catch these and start treatment, the better the outcomes are. And again, some toxicity can be managed with even just holding the checkpoint inhibitor alone. Some mild cases of neuropathy, even aseptic meningitis, but for others, you often have to escalate to much more therapy than you often use for other immune-related adverse events. And biomarkers are needed to predict patients at risk and to identify patients for early interventions. Perhaps antibodies could be a way. So I'd like to thank what I call the team neuro. This is the team that worked on the MSK retrospective review, especially Rachna Malani and Maggie Callahan, but this whole team here, Jed and Taha, Ann Bass from HSS, who actually recently started an immune-related adverse event interest group in our neighborhood, which is great, and then Erica Ritter and Phil Wong, who are working on some of the correlative work. Thank you.
Any questions for Bianca? Yep.
Yeah, am I right in assuming you would never reach challenge any of these patients with another checkpoint inhibitor?
Yeah, I think that's a question we often get. A lot of these patients develop, I would not say never. Again, we've certainly for the milder toxicity, some patients have been even continued on therapy, even with keeping a low dose of prednisone on board. Some patients who received combination checkpoint blockade have been rechallenged with monotherapy and not had problems. And some patients, after careful discussion with their oncologists and with the neurologist, they may not have, even if they developed a severe toxicity, they may not have other cancer-directed options. And so after carefully weighing the risks and balances, the risks and benefits, say, okay, well, maybe we should carefully try. You were on a combination, you developed a toxicity, let's try the monotherapy. And we have rechallenged in those situations. And I would say in about 50% of the cases, some toxicity has recurred, but there have been cases where it hasn't as well. So it's a case-by-case thing.
Certainly very scary toxicities,
Yeah.
though, and thank you for sharing your expertise, Bianca.
Thanks.
Appreciate it.